Before talking about the QRS complex, let's talk about the Q, R, and S waves individually, which together form the QRS complex. The Q wave is the first negative deflection that appears before the R wave. It represents the left to right depolarization of the interventricular septum. Normally, Q waves are not seen in the right-sided chest leads V1, V2, and V3. The R wave is the first upward deflection following the P wave. It indicates early ventricular depolarization, particularly in the apical region of the ventricles. And the S wave is the first downward deflection after the R wave, representing the depolarization of the basal regions of the ventricles, especially in the Purkinje fibers. The S wave may not always appear in every lead. So again, the Q wave, because the depolarization is in this direction and it is moving away from the positive electrode, so it will give us this small negative deflection. And the R wave, because the electrical activation moves in this direction, which is directly toward the positive electrode, so it will give us the super positive deflection. And then we have the depolarization of the base of the heart. This part is called the base of the heart. And the direction of the depolarization is away from the positive electrode. Then again, we will get another negative deflection. The Q wave in the normal circumstances are not seen in the right-sided leads V1, V2, V3, as we mentioned earlier. And the small Q waves are typically seen in left-sided leads, lead 1, AVL, V4, V5, and V6. Now, what if Q waves are present in V1, V2, and V3? If Q waves appear in these leads, it may indicate a previous anterior myocardial infarction, as Q waves in V1, V2, V3 are typically abnormal and suggest the loss of electrical activity in the anterior wall of the heart. And it is often due to the death of the heart tissue following an infarction. So this is called the pathological Q waves. And the pathological Q waves are key indicators of myocardial infarction, current or prior, and must meet the following criteria. The depth should be greater than 3 millimeter. The duration should be longer than 0.04 seconds. The depth is greater than 25% of the total QRS complex, and commonly seen in leads V1, V2, V3. In this ECG examples, we can see a deep, wide Q waves are clearly visible in leads V2 and V3, meeting the criteria for the pathological Q waves. Recognizing these abnormalities is crucial, as they often indicate a myocardial infarction, and it will help us to assess the extent of the heart damage when interpreting the QRS complex. Let's look at the R wave progression. In the chest leads V1 up to V6, which is a key feature in the evaluation of the heart's electrical activity in the horizontal plane. In a normal ECG, V1 and V2, the R wave is small because the depolarization wave moves away from these leads, which are closer to the right ventricle. As we progress from V1 up to V6, the R wave gradually increases in size, reflecting the depolarization wave moving toward the left ventricle, which has more muscle mass. The transition zone, where the R wave is equal to the S wave, usually appear around V3 and V4. By V5 and V6, the R wave is at its tallest, as these leads are closest to the left ventricle. This gradual increase in R wave amplitude is what we call normal R wave progression. Poor R wave progression. In this example, the R wave remains small and fails to show the expected growth across the precordial leads. Poor R wave progression can result from several conditions such as prior myocardial infarction. Scarred tissue prevents normal depolarization, affecting the R wave growth. And left bundle branch block, delayed left ventricular activation reduces normal progression. Ventricular hypertrophy, incorrect lead placement, because the mispositioning of the chest leads can mimic poor R wave progression. So recognizing this abnormality is essential, as it often indicates underlying cardiac pathology or technical issues. Further evaluation, including clinical history and additional tests, is a key to determining the cause. Together, Q, R, and S make up the QRS complex, which represents the total depolarization of the ventricles, the right and left ventricles. The QRS complex typically is 80 to 120 milliseconds in duration and 2.6 up to 4.5 millivolt in amplitude. So its shape, duration, and amplitude provide critical information about the ventricular function and can help to detect conditions like bundle branch blocks, ventricular hypertrophy, and myocardial infarction.